Hey, Dr. Bailey, welcome, welcome. Not hearing you. Are you muted? Yeah, you're muted. There you go. You should be on now.
Right. Hey, how you doing?
Not bad at all. I have your video, so when you're introduced, I'll make sure to play that clip that you had sent. A very
Right.
interesting clip. Um, very quite the giving yourself fillers. I won't spoil it for the viewers, but wow.
Yeah.
Yeah, looking forward to that one.
Okay, I'm actually, my fan is on. Is it interfering with the audio?
No, I have a fan here. You might be hearing mine, but I,
Uh,
I, I don't have an issue on your side.
okay, so you can hear me perfectly well.
I can, yes.
Great.
For Paul and the team at Medimpex, thank you guys once again. 1,600 plus registered. Remember, if you are going to unmute to speak and you're in the same room, you have to turn down the volume on the speakers from your other end, all right? So if you're using multiple devices in the same room, you'll have to mute. I think we're waiting on Dr. Buckland, who will be the moderator. Once she joins us, then we should be good to go. You want
So,
to,
so
in the meantime, you want to share your screen and make sure everything's working, Dr. Bailey?
yeah, no problem. So Sam, so after Dr. Buck introduces me, you just invite her to, you just ask her to share the video, and then after it is completed, I'll share my screen. So my screen is on.
Yeah, perfect.
Yeah.
Yeah, that's good.
Okay. So that's me.
All right, we're good
You
to
know,
go.
I'm always
The
called.
only thing I think you'd have to go to slideshow
Oh
and
yeah, I
start from
understand.
the beginning.
No,
Right,
I
but
understand.
other than that, we're good.
Yeah, man. So I'm good.
All right, yeah, man, good. So I have 253 persons in the waiting room. 256, number is growing. I'm sure they're gonna start calling you and saying, "Why can't we get on?" So we're just waiting on Dr. Buckland. We'll give her another 2 minutes and then we start. I see a typo there in your July 2 U's. You can just take one out.
Oh Lord, yes. But no matter how hard you try with this,
Trust me. But the good thing we see it now, so
right
everything is
there,
good.
right.
All right. So everything looks good. I'll stop you sharing for now because I'll have to share your video before, but when you're ready, you just go again. So we're just giving 2 minutes to Dr. Buckland. We should start at 7:05 if that's good with everybody.
Yeah, that's fine.
All right. Sounds good.
Have I stopped sharing?
Yeah, I have stopped sharing for you. It's
Oh,
good.
okay, right, no problem.
Dr. Buckland is here. Perfect timing. Wonderful. All right. I'm excited. I'm happy now that I see Dr. Buckland. Hi, Doc. You're muted. All is well?
Fine, thank you.
Good to see you. I'm glad Beryl never washed you away.
And you?
Yeah, hanging in there, giving thanks, taking it
Yes.
one day at a time.
Right.
Yeah.
Okay,
All right.
I was-
So it's 7:03. I think we're ready to start. Let persons in now. I have
Is Dr. Gordon here?
he sent a recording.
Okay, great.
Yeah. So I'll play his recording and then we'll take it from there. All right. So have a wonderful session, everyone. What
Thank
I
you.
will do when we start, I'll just hand right over to you, Dr. Buckland, and you can just speak to everybody and thank them for joining.
Right, thank you.
All right. Have a good one, guys.
Okay, hello everyone. This is the Association of General Practitioners of Jamaica and Medimpex Jamaica Limited annual ethics webinar. And today is July 25th, 2024. We are ready to depart. And thank you so much for joining us for this insightful and educational event, where you are going to gain valuable knowledge on the ethical and psychological aspects of dermatological care and also earn CMEs. We have two speakers today. There is Dr. Alveston Bailey and Dr. Lorena Muir-Green. Both of them are exceptional speakers and exceptional persons. At this time, I'm going to invite Dr. Donald Gordon to bring the welcome and opening remarks.
Colleagues, moderator for this evening's sessions, esteemed presenters, sponsors Medimpex, and members of the organizing committee and technical team, good night and blessings to you as we recover from the ravages of Hurricane Beryl. Hopefully, there will be no IT glitches tonight as a result of internet instability caused by Beryl. I'm Dr. Gordon, President of the Association of General Practitioners of Jamaica. It is my pleasure to welcome you and bring greetings for another in the series of ethical webinars sponsored by our very valued partner, Medimpex. Over the years, the Medimpex AGPJ webinar has grown in importance and popularity and has now become an important CME calendar activity. The theme of tonight's webinar will focus on the ethics of cosmetic surgery and its psychological impact on the patient and its overall effect on society. The talk will also look at the psychological impact of common skin conditions which causes negative body images and to look at the strategies for improving the diagnosis and treatment of these worrisome conditions. Tonight's speakers, Professor Al Bailey and Dr. Muir Green, will delve into these topics and address these very interesting and provocative issues, which I hope you, the audience, will find very informative and educational. Medimpex and the association has developed a very beneficial relationship over the years, which has resulted in these very high-class webinars. It's a relationship that the association cherishes, and we hope it will continue to flourish in the years ahead. The association wishes Medimpex a very successful webinar tonight, and hope that the knowledge imparted to you, the audience, will serve to provide you, the participants, with insights into the motivation and perceived benefits sought by patients who indulge in the use of cosmetic products, body alteration surgeries, with sometimes ending grotesque disfigurement and occasional death. Thank you very much, and good night, and enjoy the webinar. Thank you.
Thank you very much, Dr. Gordon. Please help me to welcome Mr. Paul Dennis, who is bringing the sponsors welcome from Medimpex. He's the medical representative supervisor for Medimpex, Jamaica. Mr. Dennis, I invite you to come.
Good evening. Good evening, ladies and gentlemen. It is our pleasure to partner with the Association of General Practitioners in Jamaica for this annual ethics webinar. I would like to extend a special thank you to Dr. Gordon, President of AGPJ, Lynn Thomas Hyatt, Secretary, Mr. Samuel Heron from Oldgate Solutions, and Dr. Aldith Buckland, our esteemed moderator. We are thrilled to welcome all of you, distinguished professionals, who have joined us today. Your support means the world to us, and we are grateful for your continued trust in Medimpex. In keeping with the theme of dermatology, as you may know, Medimpex is committed to providing high-quality pharmaceutical products for your patients. We distribute products related to dermatology, such as your Curiosin, Erolin, Mycosis, Terbicil, as well as mental health products like Cavinton, Palixid, and Stimulotan. Our motto is first-class products for healthy living. We strive to uphold this commitment through our work with you. I'm also excited to announce that we are now the sole distributor of Nebido, a groundbreaking testosterone injection. I would like also to introduce our dedicated medical representative team, starting with Mrs. Lisa Hubbard, Miss Sasha Dixon, Miss Paulette Bedward, Miss Melanie Miller, Mrs. Cheyenne Magoo, and Miss Tanjini Turner, our newest member. These individuals are hardworking and dynamic professionals who are passionate about delivering, they're joining me right now, who are passionate about delivering exceptional service to you and your patients. These are my team, saying hi. Once again, I want to thank you for joining us today. We hope that this webinar will be a valuable experience for you, and we look forward to your active participation and engagement with our speakers. Thank you very much.
Thank you very much, Mr. Dennis. At this time, I have somebody very special to bring the first presentation, none other than Dr. Alveston Bailey. Dr. Bailey will be speaking on ethical dilemmas in cosmetic dermatology, balancing patient autonomy, safety, and societal impact. The ethics of aesthetic surgery. Now, who is Dr. Alveston Bailey? Well, from the little bit that I know of him, he's quite a unique individual. Dr. Bailey graduated from the University of the West Indies, Jamaica, earning his MBBS degree in 1980. He did postgraduate certification and training in occupational medicine from the American College of Occupation and Environmental Medicine and launched forth on a long and illustrious career in occupational medicine spanning 4 decades. Between 1984 and 2007, he served as the Chief Medical Officer of Kaiser Jamaica Bauxite Company, and he was their occupational physician and also the medical review officer. That is a very, very, very important job. In 2011, he was appointed Adjunct Associate Professor in Occupational Health and Safety with the specific mandate to design and deliver occupational health modules at the University of Technology. Since 2016, he was the Associate Lecturer at the Caribbean School of Medical Sciences and appointed its Executive Vice Dean as at July 2023. He is the past Regional President of the Caribbean College of Family Physicians, where he served in that role between 2002 to 2006, and was past President of the Medical Association of Jamaica, 2005 to 2007. He is currently the chair of the MAJ Foundation. He was recognized and received the MAJ's President Award in 2003. And also he received Sir Alistair McIntyre Distinguished Award from the UDOP, University Diabetes Outreach Program. He is co-chair of UDOP since 2008 and wrote a book called Sexplanation. I think we can find it in our bookstores and probably also go on Amazon. So he is quite the right person to bring and deliver a presentation on ethical dilemmas in cosmetic dermatology, spanning so many years of seeing so many things. And I invite Dr. Bailey to come and unfold the intrigue that I know that he has to give to us. Dr. Bailey.
Between wealth and desire is undeniable. The more you have, the more you can attain. However, should there be limits to this unfettered access, especially when the realm of plastic surgery becomes the battleground for personal transformation? Despite the long-standing history and overall safety of plastic surgery, mistakes in this industry can have profound consequences. A predisposition to addictive behavior can lead to risky paths, as seen in Hong Mioku's case. She developed an obsession with plastic surgery that had tragic results. Initially a successful model and singer, Hang's journey into cosmetic enhancements began at 28, driven by a quest for flawless skin. She even moved to Japan for multiple procedures. Over time, her relentless pursuit of perfection. Returning to Korea, her transformation was so extreme that her own parents couldn't recognize her. Though she initially sought psychiatric help, she stopped attending sessions and sought a plastic surgeon willing to continue her treatment. She eventually found a surgeon who provided silicone injections and the necessary supplies, including silicone and syringes, for self-administration. When she ran out of supplies, she resorted to injecting cooking oil into her face in desperation, leading to severe swelling, scarring, and disfigurement. Her story garnered public sympathy, with donations made to help her regain her appearance. However, despite 10 surgeries, only some of the substances were removed, and her face size was reduced. In her 60s, Hang now works in a second-hand clothing store and relies on state assistance. Her deepest hope is to restore her original face, serving as a poignant reminder of the devastating consequences of her plastic surgery addiction. Raji Narinesing is a versatile American figure, recognized for her roles in acting, LGBT advocacy, writing, singing, and reality TV. Her most significant exposure came through her appearance on the E! Entertainment show Botched, where her challenging journey unfolded as she grappled with the removal of cement-like substances injected into her face, breasts, and hips. These complications arose from a regrettable encounter with an unlicensed practitioner who mishandled her filler injections. After a second appearance on the show, a significant portion of the problematic material was successfully removed. Raji Narina Singh's heritage is richly diverse. She hails from the Dogla ethnic group, with a father of Indo-Trinidadian descent and a mother with French, Afro-Trinidadian, and Polynesian roots. In the late 1990s, she embraced her identity as a transgender woman and embarked on her transition journey, a profound personal revelation that doesn't diminish her identity in any way. In 2005, Narina Singh sought services from O'Neill Ron Morris, known as the Duchess, for filler injections aimed at feminizing her facial features, breasts, and hips. The Duchess, a prominent figure in Miami's transgender community, was infamous for providing low-cost alternatives to professional cosmetic surgery. However, the fillers used were a perilous concoction of concrete, tire sealant, mineral oil, and glue, a far cry from the silicone Narina Singh believed she was receiving. It took her several months to realize the true nature of these injections as her body reacted adversely, leading to swelling and the formation of nodules where the harmful substances had been injected. Over the subsequent years, Raji Narina Singh confronted a profound personal struggle. She was so ashamed of her appearance that she isolated herself, rarely leaving her home and avoiding seeking treatment for the complications caused by the unregulated injections. Her journey underscores the importance of informed and safe cosmetic procedures and showcases the resilience of the human spirit when confronted with adversity. Anastasia Pokryshchuk. Anastasia Pokryshchuk, originally hailing from Kiev, Ukraine, embarked on a journey of multiple cosmetic procedures, including Botox, veneers, chin and jaw reshaping, and liposuction. While these may seem like fairly routine procedures in the world of cosmetics, the astonishing aspect emerges when you witness the finished results of her transformations. Anastasia began her foray into cosmetic enhancements at the age of 26, a decision that set her on an unconventional path. What distinguishes her story is the fact that she took it upon herself to administer filler injections, frequently relying on online tutorials to guide her through the process. She boldly claims to adhere to stringent sterilization procedures for her equipment and administers the substance in a manner akin to a medical professional attending to a patient. Her conviction in her abilities is resolute. As a consequence of her relentless pursuit of cosmetic perfection through filler injections, Anastasia has found herself bearing excessively prominent cheeks, a distinctive feature she is resolute on maintaining. In fact, she even sought to secure the title of having the world's most prominent cheeks. In a 2020 interview, she declared her unwavering commitment to self-administering fillers, even in the face of warnings from concerned medical professionals who expressed their despair at her choice between wealth and...
Thank you very much, Madam Chair, for your kind introduction. I trust that that video will provide for you some insight into the complexities of aesthetic surgery and the approach we need to adopt to avoid these complications. I'd like to thank the AGPJ and Medimpex for inviting me to make this presentation this evening. It's a very provocative presentation, and I just want to ensure that all the participants understand that my task this evening is essentially to discuss the ethics of aesthetic surgery. I will not deem to try and discuss the psychosocial issues, nor will I discuss the medical legal issues. Those issues belong to a different forum. So I will delve into some interesting evidence about aesthetic surgery and look critically at the issues that we have to contend with as physicians. So the primary objectives of this session will be to show you that short video, and then we will define ethics, We will give you a brief overview of aesthetic surgical procedures. We will discuss the principles of ethics, and then we will spend some time looking at some case studies. I trust that you'll find this presentation interesting and very revealing. Now, ethics has many definitions, but the one I particularly choose for this presentation is the one that I got from Britannica.com, which reminds us that the term ethics may refer to the philosophical study of the concepts of moral right and wrong, and moral good and bad. It refers to any philosophical theory of what is morally right and wrong, or morally good and bad, and to any system or code of moral rules, principles, or values. So what is cosmetic surgery? Well, cosmetic surgery is defined as any invasive procedure where the primary intention is to achieve what the patient perceives to be a more desirable appearance, and where the procedure involves changes to bodily function that have a normal appearance on presentation to the doctor. I've actually paused to ensure that the take-home points are highlighted. And in this particular instance, it's important to note that the bodily features have a normal appearance on presentation to the doctor. So what's cosmetic surgery then? Plastic surgery is a recognized surgical specialty and is also defined as a subspecialty dedicated to the surgical repair of defects of form or function. On the other hand, cosmetic surgery uniquely restricts itself to the enhancement of appearance through surgical and medical techniques. It is specifically concerned with maintaining normal appearance, restoring it, or enhancing it beyond the average level towards some aesthetic ideal. In contrast, the usual plastic surgeon performs surgery with the goal of achieving a normal appearance, where bodily features have an abnormal appearance on presentation due to congenital defect, developmental abnormalities, trauma, infection, tumors, or disease, and therefore this would not fall under cosmetic surgery. I find this particular paper quite interesting, published by Cradon in 2005. And he argues that as the concepts of beauty undergo changes, wrinkles, fat deposits, and sun-damaged skin no longer fit into a concept of a neat society. Dr. Petra, who published his paper in American Journal of Cosmetic Surgery in 2018, argues that we as cosmetic surgeons are indeed unique within medicine. We do not treat or seek to cure disease. What we do is reshape and reform the human body in a way designed to improve appearance, increase self-esteem, and enhance patient well-being through beauty. There are many types of cosmetic surgery, and we will not spend a lot of time discussing the techniques because that is outside of our scope. But just to remind you that surgery to the breast can be breast reconstruction, breast reduction in men with gynecomastia, breast augmentation, and breast implant revision. Fat reduction can be liposuction and non-surgical fat reduction. Body lifts can be arm lift, thigh lift, body contouring, buttock enhancement, and mummy makeover. Face and neck surgery, there are many types, from brow lift to rhinoplasty. And there's aesthetic genital surgery, which can be surgical and non-surgical. And then we have the minimal invasive, which has become very popular, Botox, dermabrasion, laser hair removal, spider vein treatment, chemical peel, dermal fillers, skin rejuvenation, and tattoo removal. So these are some examples of the multiple types of cosmetic surgical procedures that is practiced around the world. I thought this slide would be quite interesting for all of you who have joined us. When we look at the top 5 cosmetic surgery by gender, we look, and this was published in 2015, the top 5 surgical procedures are: number 1, for women, eyelid surgery, followed by breast lift, followed by breast augmentation, followed by liposuction and tummy tuck. For men, the first one is liposuction, then nose surgery, then eyelid surgery, then male breast reduction, and facelift. I thought it was interesting because I had no idea that men were so keen on facelift, but apparently in the States they are. And the non-surgical procedures that are very popular are Botox, hyaluronic acid, non-surgical fat reduction, hair removal, and photo rejuvenation for men. Similar for women, except that women tend to offer chemical peel, and the surgical ones we have discussed already. I thought I'd like you to pause to look at the most common plastic surgery procedures worldwide. This is fascinating because worldwide, the most common surgical procedure is breast augmentation, followed by liposuction. And the least common is facelift. So breast augmentation is extremely popular. I also thought I'd pause to show you this slide because when I looked at it, I was particularly intrigued because it showed that the demand for aesthetic surgery has increased significantly over the years. If you note the combination of surgical and non-surgical cosmetic procedures and that is in purple. In 1997, it roughly averaged around 1.6 million. And in 2015, it went up to a whopping 12.7 million. So it means that aesthetic surgery is becoming extremely popular around the world. I thought this slide will also be of interest to you in terms of where are the most procedures done. Now, I note that the Caribbean is not included. Perhaps they're not part of the registry. But it's interesting to note that the most procedures are done in the US, followed by Brazil, and then China. And we're going to discuss China in a little while, and Japan, and the least in Australia. Absolutely fascinating. Now, I'm not going to dwell exhaustively on the complication of cosmetic surgery. That belongs to another session. But just to remind you that cosmetic surgery is not always benign. There can be adverse health outcomes, neurologic, gastrointestinal, at the surgical site, cardiovascular, pulmonary, and systemic. So let us now delve into the main event for this evening, the ethics of aesthetic surgery. I have attempted to ensure that all the data presented to you are evidence-based, and feel free to take a photo shot of any reference that you see so that you can look at the articles in greater detail. In 2009, Chung and his team embarked on a systemic review of ethical principles in plastic surgery literature. Interestingly, despite the number and complexity of ethical dilemmas faced by plastic surgeons, Chung found a relatively small proportion of articles in the plastic surgery literature focused on ethical issues. Now, medical ethics in the United States, and I suspect all around the world these days, commonly adheres to the moral theory of principlism, first described by Beauchamp and Childress in 1979. Now, principlism involves autonomy, non-malfeasance, justice, and beneficence. Just to remind you, autonomy refers to respect for the patient's self-determination. Just to remind you again that patients have the right to accept or reject recommendations for medical care if they have appropriate decision-making capacity. Beneficence is doing what is best for the patient. The definition of what is best may derive from the physician's judgment or the patient's wishes. Non-maleficence, primum non nocere. First, do no harm. We recognize that as doctors we are fallible, and we are equally capable of harming as we are of helping our patients. And finally, justice. Fair allocation of resources should be encouraged, and patients in similar situations should have access to the same care. We're now going to discuss this in more detail. We're going to look particularly at the dichotomy of enhancement versus therapeutic intervention, the sanctity of patient autonomy, the principle of beneficence, and the imperative of informed consent as it relates to aesthetic surgery. Now let's take a look at enhancement versus therapy. Now, the demarcation between enhancement and therapy in aesthetic surgery is often unclear and raises a lot of ethical concerns. You see, reconstructive surgery aims to restore normalcy in appearance and function, but aesthetic surgery seeks to enhance appearance beyond the normal baseline, and thus we end up with this ethical debate. Aesthetic enhancement procedures such as mammoplasty, rhinoplasty, and lipoplasty, in my opinion, transcend the normative human aesthetic to take it to a different level. Critics contend that these procedures perpetuate and exacerbate societal beauty paradigms, which are frequently underpinned by prejudice and exclusionary standards. Please take a note of bullet number 2. I want to emphasize that the relentless pursuit of aesthetic ideas can precipitate psychological morbidity, such as body dysmorphic disorder, and what has now been described as surgical addiction. Sauer, in 2004, in his paper Body Image and Cosmetic Medical Treatment, argues that such activities may distort the concept of normalcy and foster an environment where natural diversity in appearance is eschewed in favor of what he described as homogenized beauty standards. We all want to look like each other. In contrast, therapeutic intervention in plastic surgery are predicated on medical necessity. So, procedures such as reconstructive surgery for burn survivors or post-mastectomy breast reconstruction are viewed as restitutive, aiming to reinstate functionality and a semblance of normality, enhancing patients' quality of life. So, Roerich, in his paper, When is Teenage plastic surgery versus cosmetic surgery okay? Is it reality or is it hype? He argues that these interventions are widely accepted as ethically justifiable and beneficial, emphasizing the restoration of form and function rather than mere aesthetic enhancement. Let's now pause to look at patient autonomy. Chung, in his study 2009, found that the most common principle discussed in the plastic surgery literature was respect for autonomy. Autonomy, according to Turkel, in the Encyclopedia of Ethics, is the ability or right to be self-governing or self-ruling. Assuming the informed consent process is complete, the patient therefore has a right to decide whether they want to undergo a surgical procedure or not. So, cosmetic surgery passes this test of being ethical. It should be noted that the patient, and I want you to pause to allow this concept to percolate through your thought processes. It should be noted that the patient does not have the right to demand a cosmetic procedure that is not in the interest of their overall health. So, Turkel argues that autonomy does not include the ability to do something that is morally wrong. Food for thought. Let us spend some time looking at informed consent. Informed consent is a foundational principle in medical ethics, mandating that patients are provided with all, and I would like us to reflect on this, all pertinent information to make enlightened decisions about their care. In the context of aesthetic surgery, informed consent has many layers. The first one I want to tell you about is comprehensive disclosure. And this was discussed by Mark Gorney in 2001. He argues that surgeons are ethically bound to provide exhaustive, and let me repeat, to provide exhaustive information about the nature of the procedure, expected outcomes, potential risks, and alternative treatments. This includes elucidating the limitations of surgery and, most importantly, and I put that in bold, managing patient expectation to preclude, avoid unrealistic aspiration. The next issue is understanding and voluntariness. Beyond mere provision of information, surgeons must ensure that patients understand the implication of their choices. This requires effective communication, enabling patients to fully grasp the potential consequences of the surgical intervention. Additionally, consent must be rendered voluntarily. It should be devoid of coercion or undue influence. The surgeon must ensure that patients' decisions are truly autonomous. Fink, in his paper in 2010, makes a suggestion here that I thought was particularly interesting, and I'd like you to reflect on this, colleagues. That he argues that evidence suggests that how long the surgeons spend obtaining informed content enhances comprehension. For example, Mac, Desian et al. Evaluated the effectiveness of oral communication compared to both oral and written communication in informed consent processes for rhinoplasty, rachidectomy, or laser resurfacing. And he found that patients receiving both oral and written communication demonstrated significantly better recall about risk of facial cosmetic procedure than patients receiving oral communication alone. This actually poses some challenges because we then have to reflect on three different standards. the professional standard, the reasonable patient standard, and the specific patient standard. The professional standard refers to disclosing the same information that other surgeons with the same training in the same clinical situation would tell their patients, and that is the professional standard. The reasonable patient standard refers to disclosing the information that a prudent or wise patient would need to know regarding the benefits and risk of an alternative to a procedure to make an informed decision whether or not to consent. And finally, the specific patient standard refers to disclosing the information that a specific patient would need to know, and I put this in bold, given his or her unique values, to make an informed decision about whether or not to consent to treatment. What about beneficence? Chung found in his paper that the next most common theme was beneficence. Now, conversation of risk and benefit falls within this ethical purview. Beneficence is the quality or state of doing or producing good. The principle of beneficence obliges us to act in the best interest of our patients, promoting well-being while mitigating harm. In the domain of aesthetic surgery, this principle is particularly difficult due to the subjective nature of what is benefit. So let us take a look at that. Is there a psychological benefit? Advocates of aesthetic surgery argues that these procedures can engender or generate significant psychological benefit, including improved self-esteem, improved confidence, and overall improvement in psychological well-being. Stewart, in his paper, Body Image and Cosmetic Medical Treatment, showed that studies have demonstrated that patients who undergo successful, and I want to underline that word, successful, aesthetic surgery often report heightened satisfaction with their appearance and an improvement in their quality of life. Conversely, I want us to reflect on this. All surgical procedures have risk, such as infection, scarring, complications of anesthesia, and dissatisfaction with the results. Bullet number 2 reminds us that the constant pursuits of cosmetic enhancement can create a vicious cycle of repeated surgery, each surgical procedure accruing more risk. Therefore, Nahai in 2009 reminds us that the ethical challenge lies in balancing these potential benefits against the risks to ensure that the patient's overall well-being is prioritized. Therefore, it behoves surgeons to exercise meticulous judgment, weighing the psychological and physical benefits against the procedural risk. What about non-maleficence, which is the third most common principle discussed by Chang? Non-maleficence means non-harming or inflicting the least harm to reach a beneficial outcome. Now, surgery, by its definition, harms the patient. In order to address this ethical principle, the contemplated cosmetic procedure needs to undergo risk-benefit analysis. This analysis is specific to the individual patient. A determination needs to be made whether a patient's expectations are reasonable and realistic. Let me repeat that. A determination needs to be made whether a patient's expectations are reasonable and realistic. Please note, colleague, and I put that in red, published in Medical Ethics in Plastic Surgery 2016. Bullet number 5 reminds us that if the expectations outweigh the potential complication, the ethical test has been met. But unrealistic expectation patients would have ethical problems. Final one is distributive justice. The least most often discussed in the ethical surgery literature. Distributive justice concerns the equitable allocation of medical resources. Justice, according to the Encyclopedia of Ethics, is a concept involving fairness, equality, and equitable treatment. Now, cosmetic surgery is usually considered to be elective in nature and thus not covered by third-party payers. Patients normally pay for these procedures out of pocket. Therefore, you could argue that cosmetic surgery is not available to all based on personal finances and therefore does not meet this ethical requirement. On the other hand, one can also argue that since patients are responsible for the cost of their own care, then cosmetic surgery does not affect the overall availability of other healthcare resources. Therefore, when using this argument, cosmetic surgery passes this test. Plastic surgery has some unique ethical concerns. The first one is the effects of reality television. Plastic surgeons, more so than other physicians and surgeons, have to grapple with reality television on patients' expectations, particularly cosmetic surgical expectations. Ethical concerns arise from reality television include misrepresentation and misunderstanding of surgical risk and outcomes. The American Society of Plastic Surgeons, recognizing this issue, has published a code of ethics, which you can download from their website. The link is noted in the slide. For example, if models used in advertisement have not undergone the procedure being advertised, it must be clearly stated that the model has not received advertised services. In addition, one should not solicit or initiate contact with a potential patient if it is apparent that this person is unable to exercise reasonable judgment in deciding whether to employ the physician's services. This one is most challenging, conflict of interest. A further ethical concern is the selection of surgical procedures offered and the financial conflict of interest the surgeon encounters. Do I offer a cheaper procedure or a more expensive procedure? And this was discussed by Zed Barr in 2008 in a paper called Dissecting the Anatomy of a Decision. The plastic surgeon is encouraged to provide to a patient all potential options and offer recommendation based on evidence and not on his or her financial interests. A tough one. That's what the ethicists recommend. Now, I'm going to take you on an interesting journey looking at some ethical challenges in aesthetic surgery. We do have some psychiatrists and psychologists in the audience, and I will not attempt to offer any advice about managing persons with body dysmorphic disorder. But I will introduce you to the concept and appeal to you that if you do have a patient who has body dysmorphic disorder, refer them to those who are trained to deal with it. Body dysmorphic disorder is preoccupation with one or more perceived flaws in physical appearance that are not observable or appear slight to others. At some point during the course of the disorder, the individual has performed repetitive behavior, such as mirror checking, excessive grooming, skin picking, and reassurance seeking, or they get involved with certain mental gymnastics, like comparing his or her appearance with that of others due to concern about appearance. The preoccupation causes significant distress or impairment in social, occupational, or other areas of functioning. And this definition was from DSM-5. Now, patients suffering from BDD frequently seek multiple aesthetic surgeries in an attempt to rectify what is deemed as perceived flaws. Bullet number 2 reminds us that despite surgical intervention, these patients often remain dissatisfied and become even more stressed out. These case studies will be informed by a lot of data. It is estimated that BDD affects 1.7 to 2.4% of the general population that's in the US, with up to 15% of patients seeking cosmetic surgery having BDD, Phillips 2005. Sarah in 2009 reported that 14% of cosmetic surgery patients had BDD. So you know that the BDD prevalence in 2005 was 15, 2019 was basically the same. I thought I'd show you this slide to pique your curiosity in that the area of the body that BDD patients seem to be most concerned about is the skin, followed by the hair, followed by the nose, and followed by obsession with weight. And there are a whole raft of other problem areas. You can take a shot of it. You can reflect on it when you go home tonight. So if a person presents with obsession with these areas, they might be suffering from BDD, but I must caution you not to make the diagnosis, but let those who are qualified to do so assist you. The ethical challenge with BDD, colleagues, is that performing surgery on BDD patients is a challenge, as it can reinforce their obsession with appearance without addressing the underlying psychological disorder. Ethical practice therefore requires a comprehensive psychiatric evaluation and possibly, and I want to emphasize this point, possibly denying surgery if it is deemed detrimental. This was discussed at length by Phillips in 2005 in a paper called The Broken Mirror, Understanding and Treating BDD. Social media influence on young adults. What is social media? We all know. Social media refers to a variety of technologies that facilitate the sharing of ideas and information among their users. I thought I'd share this data with you. From Facebook to Instagram to X, YouTube, more than 5 billion persons were found in 2024 early to social media, equal to roughly 62% of the world's population. In early 2024, 97% of users access chat and messaging apps and websites followed closely by social platforms. Now, the rise of social media has led to increased pressure on young individuals to conform to idealized beauty standards, often influenced by digitally alterated images of celebrities and influencers. We are all familiar with the present craze with the Brazilian butt. Brazilian butt is now becoming a craze. According to the American Academy of Facial Plastic and Reconstructive Surgery, 55% of facial plastic surgeons in 2017 reported patients seeking surgery to improve their appearance in selfies, a 13% increase from the previous year. We are getting obsessed with selfies, and if you do not like how we look, you might opt to get some help. This actually is a game called Golden Lips Injections, where you participate in this game and inject various substances into your lips and your cheek and assess the outcome. Fascinating. So what is the ethical challenge? Surgeon must discern whether the patient's desire for surgery stems from intrinsic motivation or external pressure. Ethical practice involves, therefore, again, thorough psychological evaluation and counseling to ensure that the person wants genuine self-improvement. Adolescent cosmetic surgery. Adolescents seeking cosmetic surgery often face unique ethical concerns due to their developing body and psychological immaturity. The American Society of Plastic Surgeons reported that over 229,000 procedures were performed on patients aged 13 to 19 in the States. I thought I'd just show you this slide because this is really interesting. I had no idea this was going on. For example, teens aged 13 to 19 in the States, a whopping 35,000 wanted to have their nose reshaped. 35,000. 8,700 want to have their hair reshaped. 8,500 wanted to have their breasts enhanced, and so on. So you can see that teenagers, colleagues, are definitely actively pursuing aesthetic surgery. So what is ethical challenge? You got to ensure informed consent and assess the maturity and motivation of the adolescent. Surgeons must carefully consider the long-term implications and potential regret associated with early aesthetic intervention. Now, I found this particular discussion when I was doing my research really interesting. And I want you to focus on this because this is really important. Are there cultural and ethnic consideration that is fueling, encouraging, activating the obsession with aesthetic surgery? Well, the data shows that patients from diverse cultural and ethnic backgrounds may seek cosmetic surgery to align their appearance with Western beauty standards. And I know there's some of you listening who might find this offensive, but that's what the data says. Look at bullet number 4. A study by Swami et al. In 2012 found that 25% of Asian American women express an interest in becoming westernized. Let me repeat that. 25% of Asian American women express interest in becoming westernized. So I decided to compare Asian beauty with Western beauty. Beauty is essentially, colleagues, in the eyes of the beholder. Why Asian women might consider themselves not to be beautiful is a mystery to me, and I cannot respond to that. But let's look at this. To my left is an Asian, to my right is a Westerner. And the Asians do not like their slim nose. They think their upper lip is too thin. They think that their chin is too small. Their cheekbones are too small. They do not like their eyelid. They do not like their pale, dongly, flawless hair. These are all mysteries to me, and I will not try to answer the reason why, but this is the data that we have to contend with. Asian American women, 25% would like to become westernized. So, what is the ethical challenge? Swami, in his paper Ethnic and Cultural Differences in Attractiveness, Perceptions of Cosmetic Surgery, recommends surgeons to navigate cultural sensitivity while ensuring that patient decisions are autonomous and not influenced by cultural pressures or internal biases. It seems as if the aesthetic surgeons have their job cut out for them. Okay then, so let us look at cosmetic surgery tourism. Medical tourism, as you know, is when a patient travels domestically or internationally to receive medical care. But in a paper by Melendez published in 2011, looking at complications from international surgery tourism, has noted that there has been a surge in popularity over the last few decades, especially in plastic surgery. Unfortunately, plastic surgery tourism can have significant ramifications. In a paper published by the International Society of Aesthetic Plastic Surgery in 2021, they did a number of studies and shown that there's increased mortality with plastic surgery tourism. A meta-analysis is the lack of appropriate post-op care with complications such as uncontrolled pain, infection, wound dehiscence, or poor aesthetic outcome that the patient must deal with independently at home. And I've had cases in my own practice with patients who went abroad to do plastic surgery and came to me for post-op care. Quite unacceptable. Often, these complications require admission into the hospital, surgical intervention, a long-term follow-up, and can pose a huge financial burden, ranging from $26,000 to over $150,000 US. It is estimated, and this is really amazing, colleagues, that 750,000 Americans travel abroad for medical care, with plastic surgery being a significant component. And this was a study published by Bookman in 2007. I presume that must be over a million now. So what is the ethical challenge with cosmetic surgery tourism? The surgeons must advise patients about the risk of seeking procedures in countries with less stringent regulation and follow-up care. Ethical practice in aesthetic surgery must include comprehensive pre- and post-op care and counseling. This, regretfully, colleagues, is not done in many instances. Let's now look at gender-affirming surgery, or GAS. GAS encompasses a variety of procedures that align an individual's gender with their physical appearance. There are many procedures that persons do to align their genitals with their perceived sexuality, such as vaginoplasty, phalloplasty, metoidioplasty, muscularized chest surgery, facial feminization, thyrochondroplasty, voice surgery, etc., etc. Vaginoplasty, colleagues, you might find this alarming, is creating a vaginal canal between the bladder and the rectum using the penis. Vulvoplasty is making a vulva out of the penis and scrotum. Metoidioplasty is turning the enlarged clitoris from testosterone into a penis. And phalloplasty is using a skin graft from the arm or leg to make a penis. Fascinating stuff. And there are more. But I just thought I'd just put this in to pique your curiosity. The most common procedure for gender affirmation surgery is breast reconstruction, followed by hysterectomy, followed by orchiectomy, and then vaginoplasty. Among patients who underwent other facial and cosmetic procedure, liposuction was next, followed by rhinoplasty, facial feminizing surgery, and chin augmentation. So, the data shows that the number of gender-affirming surgery in the USA increased by 20% from 2017 to 2018. I don't have any data for 2024, but it's reasonable to say it has not reached about possible 25%. What is the ethical challenge for gender-affirming surgery? The surgeon must ensure informed consent. The surgeon must refer the patients for comprehensive psychological evaluation, and respecting the patient's gender identity while navigating the potential for societal bias and discrimination. You have to work with your psychologist, the sociologist, and the psychiatrist. Now, post-mastectomy breast reduction is surgery to recreate breast after mastectomy. Women undergoing mastectomy for breast cancer often opt for reconstructive surgery to restore their appearance and sense of femininity. And this is a typical example. There are many types, but this is a typical example of using a donor site to reconstruct the breast. According to ASPS, in 2019, over 100,000 breast reconstructions were performed in the USA. So what is the ethical challenge for breast reconstruction? Surgeons must balance the physical and psychological benefits of reconstruction with the potential risk and complication, ensuring that patients are fully informed and supported through this process. Cosmetic surgery in older adults. I thought before I did this research that this was the primary age group that were interested in cosmetic surgery. Or was I wrong? Increasing numbers of older women, rather older adults, are seeking cosmetic surgery to maintain a youthful appearance. The ASPS reported that individuals aged 55 and older accounted for 28% of all cosmetic procedures. So a third of the persons requesting cosmetic surgery were older individuals, age 85 and more. What is the ethical challenge? We need to evaluate the health risks associated with surgery in older patients who may have a variety of comorbidity. It's pointless to offer surgery in a person who has uncontrolled diabetes and who has many other health issues, which could be aggravated by post-op complications. So, surgeons must ensure that the benefits outweigh the risk and that patients have realistic expectation. Marketing. This is a big one. The marketing practice of aesthetic surgeon can impact seriously on the patient decision-making process. A study by Crockett et al. In 2013, I thought this was interesting. I want us to pause to look at this because this is fascinating stuff. And this is evidence-based. Crockett and his team in 2013 found that 80% of cosmetic surgery advertisements were misleading, emphasizing benefits and downplaying risk. That's a lot, 80%. And that was in 2013. It might have gone up by now. So what is the ethical challenge for marketing? Surgeons must adhere to ethical marketing practices, ensuring that advertisements are truthful, balanced, and do not exploit patient insecurities. It's a tough one. That's what we need to do. Economic disparity in access to aesthetic surgery. Now, socioeconomic factors can influence access to cosmetic surgery, with wealthy individuals more likely to afford elective surgery. Data from the American Society for Aesthetic Plastic Surgery indicate that 82% of patients have incomes over 60,000 US, 2018. So, what is the ethical challenge? Surgeons must consider the implications of economic disparity, ensuring that their practice does not disproportionately cater to affluent patients while neglecting those from lower socioeconomic background. A tough one, but we have to try. Now, what are the ethical implications of non-surgical aesthetic procedures? And this has become very popular. In the cosmetic space, non-surgical treatments called non-invasive means that there's no cutting of the skin or use of surgical instruments. I just opt to just list a few. There are many. And those of you who are interested can go online and look it up. There are many non-surgical aesthetic procedures, And I will not dwell on how these are done because that is not within my domain. And the procedures can easily be looked up online. The common ones are Botox treatment, chemical peel, dermal fillers, eye rejuvenation, hair removal, laser treatment, lip reshaping, skin resurfacing, etc., etc. The popularity of non-surgical procedures such as Botox and dermal fillers raises many ethical questions regarding safety and regulation. In 2019, ASPS published that there were over 7.7 million Botox procedures and 2.7 million filler procedures done in the United States alone. Very popular. 7.7 million Botox. We do not have any data available in Jamaica, but it is getting quite popular. Now, I want you to pause to look at this data, which says that non-surgical cosmetic procedures can result in a range of complications such as burning, scarring, infection, blindness, pigmentation changes, etc., etc., and can have major and irreversible impact on health and well-being. So we know that these procedures produce good aesthetic results usually, but we need to also bear in mind that there may be severe adverse health outcome. So the ethical challenge of non-surgical aesthetic procedure is to ensure, and I want to emphasize this, colleagues, if you refer anyone for these procedures, to ensure that these procedures are performed by qualified professionals who provide adequate information about potential risks and maintain high standard of care. So if you're going to refer someone, or if you are doing this, you ought to be qualified. You ought to provide adequate information about risk, and you need to offer adequate pre, intra, and post-op care. How do we handle patient expectation? Unrealistic expectation can lead to dissatisfaction and psychological distress. A study by Cunningham et al. In 2004 found that 12% of cosmetic surgery patients had unrealistic expectation, leading to post-op dissatisfaction. Therefore, ethical challenge the surgeons are faced with is they must engage in thorough pre-op consultation to manage expectation, thus ensuring that patients have a realistic understanding of the likely outcome and the limitations of the surgery. There are some ethical considerations in breast augmentation, which is a surgical procedure where the breast size is enhanced. This can be from placement of an implant or a transfer. Breast augmentation remains one of the most popular procedures, but it involves significant ethical consideration about informed consent and long-term health effects. SPS reported that there were a whopping 300,000 breast augmentation procedures done in the USA in 2019. Very popular. So what, colleagues, is the ethical challenge of breast augmentation? We must ensure that patients are fully informed about the potential risks, such as, and I want to pause and go through this slowly, such as implant rupture, capsular contracture, and the possibility of having to do other surgery is important for patients to understand. Do we offer cosmetic surgery for persons with disability? Well, some surgeons will do so. These persons may seek cosmetic surgery to improve their appearance and reduce stigma. But there's limited data on cosmetic surgery in disability. The ethical challenge, therefore, is that the surgeon must consider the unique need and potential benefit for disabled patient while ensuring that the decision for surgery is not influenced by societal pressure to conform. In conclusion, the ethics of aesthetic surgery are intricate, entailing the interplay of enhancement versus therapy, patient autonomy, informed consent, beneficence, non-malfeasance, and justice. We recognize that while aesthetic procedures can offer significant psychological and physical benefits, they also entail risk and ethical complications. Therefore, ensure that patients are thoroughly informed, autonomous in their decision making, and that their well-being is paramount is crucial. By adhering to ethical principles and professional guidelines, surgeons can navigate the ethical terrain of aesthetic surgery, fostering the best interests of their patients. Therefore, colleagues, let me entreat you that if you do aesthetic surgery, or if you refer persons to anyone to do aesthetic surgery, that you must ensure that the surgeon has integrity and is honest. You must ensure that the surgeon displays justice and is fair. You must ensure that the surgeon conforms to the principle of non-malfeasance and don't do any harm. You must guarantee that this surgeon, whoever he or she is doing good. And finally, be considerate. Therefore, I end with this cartoon in which this doctor said, if you truly wanted to improve your image, you would stop getting cosmetic surgery. These are my references. And I thank you and trust that you have found this presentation to be elucidating and illuminating, and that it will provide you with a vision going forward for dealing with patients who need cosmetic surgery or who want cosmetic surgery. Thank the AGPG again and Medimpex for affording me this opportunity to share my thoughts with you.
Thank you very much, Dr. Bailey. We really went through a journey. And in the journey, we sensed, or shall I say, I sensed distress. And if such a person came to me, I'm going to want to explore how distressed this person is and involve other team members, as Dr. Bailey has encouraged all of us to get other team members involved, because a person may actually need to see a psychiatrist and a psychologist. He mentioned about body dysmorphism. And this condition is very serious because it is a brain disorder. It is literally a brain disorder. It's a brain-based disorder where a person is actually keeps ruminating on how they're looking, and how they're looking is distressing to them. What allows them to ruminate is the anterior cingulate gyrus, which is our brain's gear shifter. And the anterior cingulate gyrus, once it's healthy, will help people to shift from one thought to another or from one activity to another. But when there's excessive activity in this region, it is associated with people getting stuck, literally stuck on thoughts and behaviors, such as obsessing over perceived physical imperfections and repeatedly checking appearance in the mirror. Overactivity in the anterior cingulate gyrus is also commonly seen in people with obsessive compulsive disorder. You see how this comes into what he is saying? Also, it involves basal ganglia, the brain's anxiety center. These people are anxious too. This region helps set the body's anxiety level. Increased activity here is typically associated with higher anxiety levels, and it involves the limbic system. This is the brain's emotional center. The heightened activity in this region is associated with an increased risk of negativity and depression. So these persons would need to, and it's recommended that they do something called a SPECT scan, where they can find out if there's overactivity in these brain regions. Because once we can identify what is happening and the person can be shown, hey, you have activity, overactivity in these regions. Once confronted, they may accept or not accept, but it is on us to help guide the person. And we want to guide them. We want to guide them in the ethical way that Dr. Alveston Bailey has advised us. We have some questions in the chat, in the question and answer area. Dr. Bailey, we are being asked, how do you characterize the ethics of puberty blockers and surgeries in transgender in young teens? How do you characterize the ethics of puberty blockers and surgeries in transgender in young teens?
Okay, that is a challenge. I remember last year, I think, we presented a paper on ethics of gender identity. It is an issue that a lot of doctors now have to contend with because it falls now in the domain of human rights. If an individual is not happy with their given gender, it could provoke a lot of psychological conflict. And it's a decision, I think, that no doctor should make on his own, because he has to work in tandem with the psychiatrist to determine if the puberty blocker or the gender modification surgery is in fact warranted and is in the best interest of the person who requested. So I characterize it essentially as an ethical challenge that has to be resolved by a team to determine whether the person does in fact merit the intervention that he or she requests. And so it is something that has been discussed ad nauseum, and it is widely practiced in North America. And I do not know if we practice it in Jamaica, but I think it's a challenge that if you, as a physician, is not comfortable to assist in the patient in making a decision, they should be referred to someone who feels comfortable. But it could fall in the domain of human rights if a person really is so disturbed about their given gender that they develop severe mental challenges that perhaps one might have to consider intervention.
Yeah, I agree with you. All right, we have several questions in this area here. All right, so we have this other one. Is there a recommended age limit for cosmetic surgery?
No. Well, looking at the data, the only limit that they seem to require in the States is for breast augmentation. It should be over 18. But a lot of youngsters have been undergoing surgery, I presume, with their parents' permission. And as I show in the slide, they are doing a lot of youth cosmetic surgery. Breast augmentation seems to be the only one that needs you to be at the age of maturity. With respect to older person, no. If a person is going through a midlife crisis and really honestly believe that they would like to enhance their appearance, and they are hale and hearty and have no underlying medical condition, and in their considered opinion, in consultation with their doctor, they are fit to do the surgery and they are quite aware of the possible adverse outcome, then I think they should be offered it with the respect of their age. if they're fit.
Next question. In the case of gender dysphoria, concerning gender reassignment surgery, why do they not implement a gender identity clinic first before even considering hormone therapy, the way it is done in UK? Is this you're talking about the US?
I'm not sure. It's or should the list the participants of it's addressing a particular country, because I don't think we have the challenge in Jamaica or even the Caribbean.
Yeah. Next question. Could you say what is the percentage of cosmetic surgery in Jamaica by age and gender?
Excellent question. I've searched long and hard for data re-cosmetic surgery in Jamaica, and I do not have the data. Apparently, if you're a member of the Aesthetics Surgical Society, they require that you send in data annually, but I have no data in Jamaica. What I know is that it is widely practiced, especially non-invasive surgical procedures. And I doubt if many of the practitioners report the number of cases that they do and the type of cases that they do and any adverse outcome that might have happened. I doubt.
Okay. Next question. Does body piercings present as a similar psychological issue as cosmetic surgeries?
Body piercing, you know, it's quite, that's an interesting question. It is, in a sense, it is really not cosmetic surgery. I suppose it is, but to me, it is enhancement, but body piercing, in most cases, is fairly benign. It does have complication, but you're really not changing the structure. You're just decorating the structure. Therefore, I wouldn't think that it is aesthetic surgery at all. It is, to me, my own personal opinion is that body piercing is decoration.
Yeah.
It's not modification.
What are the complications for breast reduction procedures, and how long is the healing period?
Ouch, that's a tough one. I
Yeah.
would yield to a surgeon in the audience. That's a tough one, because the reconstruction procedure has the usual complication. It's a long procedure, therefore there's anesthetic complication. You have to transfer a flap from one region of the body with intact nerves, intact arteries, and intact veins, and place it in the region of the breast and anticipate that it will take. Therefore, there's always a risk of infection, there's a risk of bleeding, and there's also the risk, of course, of the flap not taking. So I didn't dwell on that in detail because I could have looked that up, but I do know that it is not benign, and because of the risk of infection, post-op bleeding, and failure of the flap to take, the patients who undergo it must be advised, and we do a risk assessment of the likelihood of it happening and the consequence, and make an informed decision. But I do not have the data on me with respect to what percentage get infection, bleeding, and failure of the flap to take, or dissatisfaction with the result. Because in fact, in many instances, the biggest complaint patients have with respect to any such procedure is that one breast might be smaller or larger than the other, and it has a different shape. Therefore, there's a big risk in terms of dissatisfaction with the result. I can't comment on, but I don't want to say it is high or low. I'll say that it is significant.
This is a good question to end on. Is it prudent to perform a psychological exam prior to performing the first surgical procedure for any patient? They're talking about surgery.
Yeah, the answer is obviously yes. I mean, my advice, there's 700 and roughly 800 persons who are listening to me. I'm sure you've had I've had patients who have come to see me and is adamant that they need breast enhancement because in their opinion, their breasts are too small. In my opinion, the breasts are quite appropriate. And the patient advised me frankly that it is my breast and I'm not pleased with how it looks and I need it to be modified. And I therefore yield in those instances to a psychiatrist, psychologist to talk to the patient to see if their concerns are justified. And as you said, Dr. Buckland, you might have to take them through a series of psychometric, psychological evaluation to see if, in fact, their concerns are real and whether they would benefit from any such intervention.
Yeah, and the patients, from how you have actually described it, you can sense how distressed the persons are who go to the lengths and breadths of the world and at whatever cost to do these things. But these people are mightily distressed. I know clinics offer what they call SPECT scans, where they have seen actually increased activity in the regions of the anterior cingulate gyrus, the basal ganglia, and the limbic system. You can do your own research on it. However, if I did encounter somebody like that, I would definitely need a team approach involving the psychologist and the psychiatrist. The family needs to be involved. You need a support network, and whatever interventions are necessary. But you just need to be with the person along their journey so that they don't feel left alone, because they're having a lot on their plate, and it is sometimes it's imaginings and it's what they're telling themselves, literally what they're telling themselves. However, it is we want to respect their autonomy and go through the whole range of the ethical pillars. Dr. Bailey, thank you so much for presenting on this very important topic, ethical dilemmas in cosmetic dermatology, balancing patient autonomy, safety, and societal impact. You did an excellent job. Thank you.
It was a pleasure to share my thoughts with all of you, and good night.
Thank you. Good night. At this time, we're inviting Mrs. Lisa Hubbard, medical representative of Medimpex, to bring the sponsor's presentation. Mrs. Hubbard?
Good evening, ladies and gentlemen. This is Lisa Hubbard, one of the medical reps here at Medimpex Jamaica Limited, where we carry first-class products for healthy living. This evening, I'm just going to do a brief overview of a few of our products. You probably know them all, so it will just be some reminders. Okay, the first one is our Stimulotan, which is sertraline, and this product has been on the market for over 20 years, so it's well known. So why Stimulotan? It's a selective serotonin reuptake inhibitor, which is a SSRI. And they act within the brain to increase the amount of the neurotransmitter serotonin in the synaptic gap by inhibiting its reuptake. This helps to ease the symptoms of mood disorders such as depression and anxiety. SSRIs have become the first choice treatment for depression owing to their excellent efficacy, safety profile, side effect profile, and onset of action. So the indications: depression, panic attack, and obsessive compulsive disorders. The dosage for depression and OCD, 50 milligrams once daily with food. Complete therapeutic effect expected after 2 to 4 weeks. And for panic disorder, week 1, 25 milligrams once daily with food. Week 2, 50 milligrams once daily with food. And expect complete therapeutic effect after 8 to 12 weeks. The maximum daily dose for Stimulotan is 200 milligrams. And remember that Stimulotan is scored, so you can get 25 milligrams from the tablet. Dosage adjustments in special populations. In the elderly, no reduction necessary. For renal impairment, no modification of dose necessary either. Hepatic impairment, a low dose or the usual dose with longer dosage intervals. And pregnancy, safety has not been established, and in nursing, it's excreted in the breast milk, so not to be used while nursing. Stimulotan is covered by NHF. It's very affordable. With NHF, the cost is $95 per tablet. So Stimulotan lifts you from the worst. The next product I'm going to do is our Curacin. And Curacin is a wound care preparation designed for quality wound healing. Curacin is a clear, non-irritant, highly biocompatible product supplied as a gel for the management of various types of wounds. So how does it work? It provides a moist environment necessary to facilitate physiological wound healing. The viscoelastic matrix form facilitates granulation and epithelialization, and it protects the cells against free radicals, resulting in reduced tissue inflammation and the control of wound pain. So indication for Curacin, management of chronic wounds of different origin. So your venous leg ulcers, diabetic foot, arterial leg ulcers, etc. And the management of minor injuries, slow healing wounds, like your household injuries, lacerations, burns, first and second degree burns, your sunburn, it works for all of those. Recommended dosage and application. Clean the wound, complete debridement if needed by gently rinsing with 3% hydrogen peroxide or saline. You can apply the Curacin in a continuous thin layer, 1 mm of the gel to the entire compromised skin area once daily. And remember, you can mix this with an antibiotic ointment as well before application. Cover with a non-stick gauze dressing and a self-adhesive bandage, but this is optional. Curacin is covered under NHF and is covered under diabetic and vascular disorders. The price for a tube is $1,100 with NHF, and you're allowed 2 tubes for the month. Our next product is Turbicil. And Turbicil is our terbinafine, and it's an antimycotic with a broad spectrum of antifungal activity belonging to the allylamine group. It can be administered both locally and systemically. And how does it work? It interferes with the fungal sterol biosynthesis by inhibiting the squalene oxidase in the fungal cell wall, which leads to cell death. As a unique fungicide agent, terbinafine provides efficient treatment for the systemic therapy of fungal infections caused by dermatophytes. So indications are your mycosis capitis, mycosis corporis, pityriasis versicolor, your mycosis curis, and mycosis pedis, and of course onychomycosis. These are your dosings. Adults get 1 tablet, 250 milligrams per day, and children, remember, it works by weight and not age. So 20 to 40 kg, they get the Turbicil Kid, which is 125. Above 40 kg, they're to go to the adult dose, which is 250, and below 20 kg and above 2 years, they take half of the kid. And these are your dosings here for your patients. So we do have all the formulations: Turbicil Kid, 250, and a Turbicil Cream, and these are your prices. Our second antifungal is our Mycocyst, which is our fluconazole. It comes in 150 and 200 milligrams. It's a bis-triazole derivative. It's fungistatic for systemic fungi and dermatophytes. Food does not affect the absorption. Bioavailability is over 90%. It's low protein binding. Least effect of all azoles on liver enzymes. Very good tissue penetration, half-life of 20 to 30 hours, and is excreted unchanged. So that offers once weekly comfort therapy. These are your indications, and normally it's 150 to 200 milligrams per week for most of the indications. And these are how they look. The 150 is approximately $1,000 at the pharmacy, and the 200 is approximately $850. So the 200 is more affordable than the 150. And I must speak about Sorbifer today. I cannot not do a presentation and not do Sorbifer. So this is our Iron Strong All Day Long. And Sorbifer allows for the gradual release of active substances for 6 to 8 hours, and this facilitates comfort dosing. And what does this mean? It means less chance of constipation due to slow release of ingredients. It's also enteric coated, and this results in less chance of GI irritation. Faster absorption of iron due to vitamin C, and it's a small odorless tablet, very easy to take. Ingredients are 320 milligram ferrous sulfate, which is equivalent to 100 milligrams of elemental iron, and 60 milligrams of ascorbic acid. So your indications: prophylactic treatment of iron deficiency and therapy for latent and manifest iron deficiency, your anemias. Adults and children over 12 years old, 1 tablet to be taken twice daily, swallowed intact, with half a glass of water at least 30 minutes before a meal. In pregnancy, 1 tablet once daily for the first 6 months. In the last trimester and nursing, 1 tablet to be taken twice daily. Sulfur is very affordable and it's $31 per tablet retail. And lastly, our good old Aerolin, which we all know, we still have it and it's still very available, both in the liquid form and the tablet form. So that's it from me this evening. I hope you have a wonderful evening and thanks very much for attending our webinar. Good evening.
Thanks very much, Mrs. Hubbard, for that wonderful presentation on the products that Medimpex carries. At this time, I invite Ms. Sasha Dixon, medical representative for Medimpex, to introduce our next speaker, Dr. Lorena Muir-Green.
Good evening, ladies and gentlemen. Dr. Lorena Muir-Green graduated from the University of the West Indies. Is everybody hearing me? Okay, great. Dr. Lorena Muir-Green graduated from the University of the West Indies, first obtaining a double major in chemistry and biochemistry in 2002. She then went on to pursue a career in medicine at UA. Upon graduating in 2007, she went on to pursue postgraduate specialization in clinical dermatology at Cardiff University, for which she got distinction. She was a recipient of the 2013 Fellowship in Hair and Scalp Disorders at the University of British Columbia. She's a member of the American Hair Research Society, International Society of Hair Restoration Surgery, and is the current vice president of the Caribbean Dermatology Association. She's a past president of the Dermatology Association of Jamaica and is a member of the Dermatology Specialty Board at UA. She is the head of dermatology at the Cornwall Regional Hospital in Montego Bay, where she conducts a once-a-month hair and scalp disorder clinic. She also conducts a hair loss clinic at the Dermatology Clinic at the National Chest Hospital in Kingston, which she first established in 2014. She has presented at various conferences, including the American Academy of Dermatology, Caribbean Dermatology Association, Medical Association of Jamaica's annual symposium, and the American Hair Research Society annual meeting. She has a keen interest in cosmetic chemistry and hair care. Through that, she has established a blog on the science of hair loss and hair care on www.askthehairdoc.com with associated social media pages. She can also be found as Dr. Lorena Muir-Green on Facebook, Instagram, and X, formerly Twitter. Welcome, Dr. Muir-Green.
Good evening.
Dr. Muir-Green, thank you so much. And as you come, I just want to let you know how much we appreciate you being here as you present on the psychological impact of dermatological conditions, strategies for improving patient self-esteem and mental health. Over to you.
Thank you for having me. As you can hear, I don't sound very wonderful. I actually am recovering from COVID. Yes, COVID is still keeping. But I'll try my best to push through. Thank you again for having me or inviting me to present this very interesting topic on the psychological impact of skin diseases. Can everybody see my presentation? I'm going to stop my video because I'm going to be blowing my nose several times and I don't want to distract you.
So we're seeing the PowerPoint. I think we just need you to go to slideshow view now. Yep.
So today I'm going to be talking about the structure and function of skin, what is psychodermatology, psychiatric diseases and associated skin disorders, dermatologic disorders and associated psychiatric disorders, dermatologic side effects of psychiatric drugs, psychiatric side effects of dermatologic drugs, and go through a few cases with you, emphasizing the need to come in with a correct diagnosis from early and strategies that we can employ for as physicians in treating our patients with skin diseases. So as you know, the skin is the largest organ of the body, and you can see here the epidermis is the outermost layer. Underneath, you have the dermis and the hypodermis, which has the sweat glands, fat, and nervous tissue, as well as blood supply. The function of the skin, mainly to protect the body. It is the first barrier against microbes. It participates in innate and acquired immunity. It mitigates against UV skin damage and protects against chemical damage, physical as well as physical damage. It helps with temperature regulation by with the fat pad keeping you warm and cooling through sweat, and of course vitamin D production, and its role in bone metabolism. With respect to communication, there is the aesthetic appearance, which is the most important thing with respect to our talk today. And as you know, it conveys certain sensations such as heat, touch, and vibration and pain. First, they're looking at the skin diseases and mental health. The global burden of diseases studies demonstrate that skin diseases were the fourth leading cause of non-fatal disease burden. Healthcare costs incurred from skin diseases in the USA amount to about $75 billion. And as you imagine, that's a lot of money. In Jamaica, we don't have similar studies, but I can tell you from data that I had collected when I was president of the DAJ a few years ago, about 10% of primary care sees dermatologic cases, and another about 5 to 10% of the primary care is responsible for or sees wounds cases. The psychological burden is heavy as the skin, hair, nails are visible, and psychological burden is increased in certain sectors, especially those in entertainment, prominent personalities, hotel industry, sales reps. Any kind of stressor will aggravate any existing skin disorder. And as we all know, major stressors worsen or trigger telogen effluvium, which is resting face hair loss. And these include death, divorce, bankruptcy, major illness, and surgery. In Jamaica, we're a little bit brash, or in the Caribbean in general, we're a little bit brash, as you know. We have a tendency to just point out flaws to the most random people. Persons who know you, your family members, etc., will say, or even your co-workers, you get fatty, how your face stays so? How him stays so? How much AIDS him have? Patients with generalized skin conditions are often scorned by family members, the general public, and this, of course, all of these things that are happening to them, they feel ashamed of themselves and tend to limit their social interactions, and including persons stop going to the beach or the river. They don't, or if they do, they don't wear anything that is very revealing. They shave off their hair, especially in Black men with male pattern hair loss and alopecia areata. The skin and nervous system develop together in the fetal stage and remain connected for life. between 30 to 60% of patients with chronic skin diseases have some sort of psychiatric problem stemming from low self-esteem, major depression, anxiety, body dysmorphia, as Dr. Bailey was discussing. Many psychiatric patients also suffer from skin disorders, either from the primary disease itself or side effects of their medications that they take. Now, because there's such a link of psychiatry and dermatology, there is an entity called psychodermatology. This is the treatment of skin disorders using psychological and psychiatric techniques by addressing the interaction between mind and the skin. And there are many psychiatric disorders can involve the skin, either directly or indirectly. Lots of psychiatric disorders develop secondary skin disorders, such as major depression and anxiety, and many primary psychiatric illnesses have associated skin disorders. There are centers, especially in the UK, that have a psych-derm unit. Unfortunately, there's no real proper categorization of psychodermatology. So I've seen various, about 3 different articles discussing this and various classification systems I've seen. This one looks at the psychophysiologic disorders, psychiatric disorders with dermatological symptoms, dermatological disorders with psychiatric symptoms, and the side effects of psychiatric drugs. Another looks at, again, with this particular breakdown, the psychophysiologic disorders, including your psoriasis, etc., your psychiatric disorders with dermatological symptoms like your dermatitis artifactor, your dermatologic disorders with psychiatric symptoms such as vitiligo, and miscellaneous, including cutaneous sensory syndromes such as vulvodynia, psychogenic purpura syndrome, and suicide in dermatology patients. Another categorization that I saw where they again had a 3-pronged categorization system where they looked at psychophysiologic or psychosomatic disorders, primary psychiatric disorders, as well as secondary psychiatric disorders. And that is how they had demonstrated in their categorization. First, we're going to look at primary psychiatric disorders and skin diseases associated. Now, I'm not going to be, it's a lot of conditions that are associated with skin disorders. I'm not going to be going into their definitions, but I wanted to take into consideration that these are some of what our psychiatric patients are experiencing or can experience. First up, we have anxiety and stress. Stress alone worsens any pre-existing dermatologic condition. The relationship between stress and the skin is bidirectional. Stress worsens skin disease, and skin disease can worsen stress. At least 13% of dermatology patients have an anxiety disorder. Skin conditions that worsen with anxiety include psoriasis, acne, and herpes simplex. Neuroimmune mechanisms show association of vasoactive neuropeptides, lymphokines, and other chemical mediators. Autonomic nervous system and hypothalamic pituitary adrenal axis are activated in stressful conditions, and this can result in the release of T cells releasing hormones and neuropeptides. Kaga et al. Showed that this particular study that the translocator protein, formerly called the peripheral type benzodiazepine receptor, acts as a stress anxiety biomarker. In this study, they were able to show that it's not, not the best design study. They were able to show that as the stress increased, the TSPO also increased. And it was markedly increased in patients with atopic dermatitis versus normal subjects. Body dysmorphic disorder. As you know, this is a psychiatric condition characterized by extreme preoccupation with self perceived defects or flaws in one's physical appearance. And the common complaints that these patients present with include enlarged pores, increased hair, perceived sunken or raised sections of skin, herpes infections, or even perceived herpes infections. I've had patients who came in talking about that their skin was dented and there was nothing that you could see. Things that they tend to do to hide or try to disguise what is happening to them. They might wear a lot of makeup that could become comedogenic and worsen their acne. They can have exacerbation of their eczema due to over application of skin products. And as you know, more is not necessarily better. Lots of the skin products nowadays have a lot of alpha hydroxy and beta hydroxy acids and other actives that such as retinol, etc., that can irritate the skin, and if slathered all over the body in copious amounts can cause significant irritation. Hyperpigmentation from irritant products. From these irritating or irritant products can cause hyperpigmentation, or can result in hyperpigmentation. And of course, you would probably see that mostly in our skin bleaching population. Okay, so a lot of our patients who have skin bleaching, they come in with a lot of redness, ochronosis, which is an irreversible type of hyperpigmentation. They also present with other types of hyperpigmentation, as well as other skin diseases secondary to their bleaching, such as extensive tinea corporis, extensive body acne. Psychosis and psychotic disorders. Now, with patients with schizophrenia, they often experience high levels of social stress, and there has been an association with inflammatory conditions and schizophrenia, and these include psoriasis, atopic dermatitis, and hidradenitis suppurativa. There's a particular genodermatosis called Diarrhea disease. Don't worry about it. It's not a very common condition that has a 2 to 0.3 times the risk of developing schizophrenia. Other things that patients can experience in schizophrenia and other psychotic disorders include burning, itching, crawling sensation. Delusion disorder. The most common thing that presents to dermatology in this category is the delusions of parasitosis. This is where they would come with describing infestation of insects, worms, parasites, and mites. And they carry what they call the baggy sign or the matchbox sign. So they literally carry a bag of their dead skin cells saying, look, doc, you can see that there are all of these insects and they're all over me and I can't sleep, it's distressing. Thing about it is that when you look at it, there's nothing to be seen. And you can't really convince them otherwise, but it does take a little while to get through to them. It can be associated with medical disorders or the use of some drugs such as B12 deficiency, vitamin D deficiency, and iron deficiency. It can also be associated with schizophrenia. Drugs that can trigger this include cannabinoids, amphetamines, and antidepressants. Bromidrophobia, which is a delusion of body odor. Every now and then I will see one of these patients coming in, and this can result in over grooming because they describe I'm smelling bad, which is called a bromhidrosis, and they're reporting that they smell bad, but the relatives are not telling them that they smell bad or smell in any way, and they significantly have changes in their daily routine, including excessive showering, use of products such as wipes, body makeup wipes, etc., to clean off the skin. And depending on what you use, those preservatives in those wipes can cause allergic contact dermatitis. They will decline social activities and avoid exercise or activities that result in sweating. Morgellons disease is where they describe they have fibers embedded into the skin or emerging from the skin and is related to delusion of parasitosis. Now, the treatment of this is to actually give them a risperidone or olanzapine, but it requires them actually being receptive to the idea. And oftentimes when we try to refer them to the psychiatrist, they are actually very resistant. Of note, they're not usually kept on these medications for very long. They're usually kept for about maximum up to 6 months, and they usually resolve after getting this treatment. Major depression, 32% of dermatology patients are estimated to suffer from depression. Several dermatologic diseases are associated with depression, including psoriasis, other conditions like lupus, especially cutaneous lupus. There is an increased inflammatory markers noted in depression, which further impact on the skin. And these include the release of TNF alpha and other inflammatory cytokines, which then trigger the development of the conditions like psoriasis and atopic dermatitis. Patients with depression have also been found to have to show evidence of dermatitis artifacta, where they have these bizarre looking, typically symmetrical bruises, etc., on their skin, cutting and or self-harming, excoriations such as skin picking, nail biting, nail picking, and trichotillomania, where they're picking out the hair, or trichotillomania, where they're actually cutting the hair in bizarre ways or actually shaving the hair in bizarre ways. Other things that they might see in persons with major depression include psychomotor agitation, such as rubbing and picking and scratching, and increased pruritus secondary to sleep disturbances. Somatic symptoms and related disorders. Again, you will see this, they typically complain about generalized itching, cutaneous dysesthesia such as trichodynia and glossodynia. And with the trichodynia, what that means is that just the moving the hair on the scalp is painful. So combing the hair is painful, moving the hair in any form, in any direction is quite painful. They can also experience numbness, hyperhidrosis, and purpura. Other associated conditions include psoriasis, nodular prurigo, and burning mouth syndrome. Obsessive compulsive disorder. 5% of dermatology patients have been found to have this disorder, and manifestations include acne excoriae, which is what most people do, where they pick at their acne bumps, and they also can experience trichotillomania, hand eczema from excessive hand washing, biting of the nails, or the picking of the nails, biting of the cheeks, evidence of excoriation, scratch marks, and other abnormal marking on the skin. Eating disorders. Main ones that I would talk about today is anorexia nervosa and bulimia nervosa, but there are other ones like orthorexia and binge eating disorder. They can present with cheilitis, lanuga-like body hair, generalized pruritus, likely secondary to anemia, carotenoderma, where you get yellowing of the skin from beta carotenes. So they can probably develop this obsession with, I'm going to only eat pumpkin alone. And they're eating, the only starch is pumpkin, no rice, no banana or anything like that. they're only eating pumpkin or other such vegetables that yellow their skin. Telogen effluvium, which is resting face hair loss, brittle nails and hair, hypertrichosis, and dry skin and hair, and gingivitis. Factitious disorder. This is where we mostly see dermatitis artifacta, and lesions are typically symmetrical with sharp or angular borders. There are burns, unexplained burns, or unexplained scars and blisters, ulcerations, signs of picking, scratching, biting, etc. And sometimes persons inject feces and blood and other foreign substances into the skin. So as you can see here on the left, these, well-defined, not randomly placed, hyperpigmented and erythematous patches, indicating that, and more than likely they're on both limbs, upper limbs as possibly lower limbs, and they are used due to some sort of object, more than likely like from a cigarette or some other item that can cause this this imprint in the skin. Pardon me. So in summary, there are many psychiatric disorders that cause dermatologic diseases, and stress, there's a direct association. Phobias, dysmorphophobia, delusion disorder, depression, impulsive control, eating disorders, which give you whether indirect or direct methods, and psychogenic pruritus, indirect via anxiety. Now I'm going to turn the focus to dermatologic disorders and associated psychiatric illnesses. Believer et al. Did a study in Norway showing that persons in a dermatologic clinic, or that if they had a skin disease for more than about 7 years, or at least for 7 years, they were more than likely going to develop a psychiatric disorder. Conditions that were seen in the clinics included depression, anxiety, and alcohol abuse. Other European studies have also shown similar results, and they also showed increased risk of acne, atopic eczema, hand eczema, hidradenitis suppurativa. In some of these studies, they were able to show that approximately 10% of psoriasis patients suffer from depression. No comparative study has been done in the Caribbean, unfortunately. Gisondi et al. Published in the Journal of the European Association of Dermatology and Venereology in 2023. And what they had done was an online-based population study conducted over 27 European countries, including Switzerland, Norway, UK. In total, there were about 19, less than 20,000 participants, and less than half of the participants were men. And what they were found was that 88% considered their skin disease embarrassing in their personal life. 83% considered their skin disease embarrassing in their work life. Their quality of life was severely impaired with, especially with hidradenitis suppurativa, and 14% felt that they were rejected by others because of their skin disease. 19.2% have been looked at with disgust, or noticed others looking at them with disgust. And anxiety and depression most frequently reported mental health issues in these clinics, in the study, sorry. Pardon me a second, please. Right now, I'm going to be discussing the cutaneous effects of psychiatric medication. Drug reactions are one of the most commonest things that most persons will see in all areas of medicine. And erythema multiforme can get that from bupropion, clozapine, and fluoxetine. Dress syndrome from carbamazepine, amitriptyline, valproic acid. Stevens-Johnson syndrome with alprazolam, duloxetine, and sertraline. Erythroderma from lamotrigine and lithium. Other reactions that have been seen in patients on psychiatric medications include hyperhidrosis, seen with fluoxetine and haloperidol, urticaria with risperidone and olanzapine, telogen effluvium with bupropion, duloxetine, and venlafaxine, cutaneous vasculitis with clomipramine, seborrheic dermatitis with haloperidol and risperidone, acne with trazodone and haloperidol, and psoriasis with benzodiazepines. And this is not, there's a more extensive listing of other cutaneous side effects of psychiatric medications out there. And when persons start these medication, you may have to look out for these developing. Right now I'm looking at the dermatologic drugs triggering psychiatric disease. The most talked about drug that cause, or most controversial drug in dermatology that causes, that has a lot of discussion regarding its use is roaccutane, because it has been associated with major depression and suicidal ideations. There are so much so that the company Roche has would give out consent forms for patients to sign, indicating that they would not share their medication with others, lest they develop any of these side effects, or they develop or they can result in teratogenesis. Sorry, pardon me, I'm really working on this, sorry. And problem with roaccutane is that, yes, it is the yes, it is technically the cure for acne. However, patients are likely to have, sorry, excuse me a second, please. I will just go on to the other below the roaccutane, sorry. Below is a table showing the list of drugs, some of the drugs that you can experience side effects that we give typically in dermatology for many conditions, and we can get psychiatric side effects. Cyclosporine, you can get pseudotumor cerebri, and resulting in headaches and tremors, etc. Methotrexate can result in psychosis and mania. Interferon can give result in depression and suicidal ideation. Tetracyclines also can give you pseudotumor cerebri as well as fatigue. And these are some of the things that we have to take into consideration when we are prescribing these medications for our patients. As you know, we tend to prescribe a lot of tetracyclines for our acne patients. And if, for instance, we want to give our acne patient both isotretinoin in the beginning, there is or roaccutane, which is isotretinoin, you will have a initial rebound acne at the start, and they can be such a profound flare of the acne in the beginning of the treatment, and we tend to give antibiotics as well. So it's not good to actually to give both the isotretinoin along with the tetracyclines. It would be better to give it with another antibiotic or another class of antibiotics, such as your clindamycin or your azithromycin, which have been quite useful in the management of acne. Now I'm going to be talking about cases that I've come across working in dermatology, and some of these could have been easily rectified from very early. However, I wanted to point out to you all that the interplay of derm and skin is so connected, and there are so many psychosocial aspects of the common Jamaican out there that impact on how they're perceived in life, how they are be able to progress in their workplace, and how they interact with others. Case one, this is a 14-year-old female presented to the dermatology clinic when I at KPH, when I used to work at the KPH/Chest Hospital clinic. She had a 4-month history of hair loss, and she was treated for ringworm. She was given Briseofulvin, then terbinafine tablets, and ketoconazole shampoo. The school sent her home midterm, 4th form, which is 10th grade, because they were saying that they didn't want her in the school looking like this. She went to a prominent high school in St. Catherine. When I looked at her, she had a large patch of scarring alopecia with loss of follicular osteal, hypopigmentation, and erythema and scaling. This is not her photo on the right, but this is something similar that she had at the time of presentation. And you can see here, there's some, not the greatest photo, unfortunately, or it's not projecting very well, but there are areas where there is follicular plugging, and which that patient also had, as well as thinning of the hair in the affected area. And what this patient actually had was discoid lupus. And as you know, discoid lupus is cutaneous lupus and may be associated with systemic lupus. And the longer the patient has it, the more likely they're to develop systemic lupus. There's a 5 to 10% chance of developing SLE over time, and must screen for the development of systemic lupus. It likes a photo, the exposed areas, such as the scalp, the ears, the face, and the upper limbs. And in the early stages, once you treat it quickly enough, you can grow back all of the hair. In the end stage, discoid lupus, you can get white vitiligo-like burnt out atrophic patches, and the hair will never grow back. Now, as you can see here, this is one of our patients. She had nothing, what this person here presented with these erythematous tender patches in the back of the scalp. And some of them had follicular plugging, but it's not very evident in this photo, unfortunately. Something to take home that most of you need to know about is that teens and adults are unlikely to develop tinea capitis. So there was no need for the school to insist that she had to stay away from school. Most teens don't do roughhousing, tackling like little children do, and so they're less likely to spread it to other children or other teenagers. And even with children, when we get children coming in with tinea capitis, once they start the correct dosing and using the topical antifungals, they're less likely to spread it to the other students. Unfortunately for this patient, she had to repeat fourth form. Case number 2. This is an 18-year-old male referred with hair loss for several months and was treated with terbinafine twice with no response. Examination showed patches of alopecia with skin smooth as a baby's bottom. This is him on the left, not the greatest photo, unfortunately. However, as you can see, no evidence of no scaling, no erythema, no papules or anything indicating that there's some sort of infectious or inflammatory process going on there. This is a photo of another patient with the same condition. And as you can see, the skin is quite smooth. And if under dermoscopy, they would actually have, you will see the retention of the follicular ostia. In this case, the person actually had alopecia areata. So just to briefly go through with you all, causes of localized alopecia include non-infectious, including alopecia areata, trichotillomania, nevus sebaceous, and aplasia cutis, where they are born with a section of the skin actually missing. Infectious causes include tinea capitis and folliculitis. With alopecia areata, the majority of patients present with this condition, have an autoimmune, may have an autoimmune disorder, another autoimmune disorder associated with it. It is seen more commonly in children than adults, and the incidence is approximately 0.1 to 0.2% in any population. Lifetime prevalence approximately 2%. So stress plays a major role in the development of alopecia areata. And again, as I had said before earlier, that stress releases certain cytokines and other inflammatory chemicals that actually will trigger certain conditions. And one of them is alopecia areata. And a lot of our patients are on some major exam, such as GSAT, well, no longer GSAT, but PEP, your CSEC, etc., presenting with alopecia areata. Of note, they're often associated condition with atopic eczema, and again, other autoimmune diseases such as lupus can present with alopecia areata. Again, the presentation, well-circumscribed patches with exclamation hairs are seen, hair follicles are present. They can, however, result or progress to involve the entire scalp, called alopecia totalis, or the entire body, which is called alopecia universalis. Nail pitting can also be a presenting sign and tends to indicate worse prognosis. Workup for both alopecia areata and discoid lupus, complete blood count, UNEs, LFTs, thyroid function test, ESR, CRP, urinalysis. Iron studies, including the ferritin. I tend to do this a lot because a lot of persons forget that the ESR and CRP can be normal, but the ferritin can be quite elevated in any of the autoimmune diseases. Also do the autoimmune panel with just the ANA, double-stranded DNA, rheumatoid factor, and ENA panel. Now, a lot of persons would be wondering, why would you be doing the ENA panel? Because we've had patients who present, and remember the ENA panel is the extractable nuclear antigens, and these include your SSA, SSB, your anti-Smith. And some of our patients come back ANA negative, but anti-Smith positive. And remember, anti-Smith is associated with lupus. And they could also be RNP positive, in addition to the ANA being positive. And if the RNP is positive, they more than likely have mixed connective tissue disease. So that is why there's an extensive panel is done on these patients. And if they come back negative for now, you'll probably revisit, depending on how they, going through, asking them development of symptoms in at least once a year, development of any other symptoms of any other autoimmune disease, and revisiting a full autoimmune panel if necessary. Lipid profile, interestingly, should be done for all patients for alopecia areata because almost all have hypercholesterolemia, including children as young as 5 years old. And we're not exactly sure what is the connection, but patients, including vegans, have also been found to be have hypercholesterolemia with alopecia areata. And again, the treatment for both the DLE and the SLE, potent corticosteroids. Even on the face, you would use the betamethasone to put on the DLE. In alopecia areata, we can use Dithronol, which we don't really have out here. There's some over-the-counter products that have Dithronol in them, such as Rector's Remedy, and sometimes I have my patients mix that along with the betamethasone for to put in their scalp for the alopecia areata. Topical immunotherapies with diphencyprone can be used for alopecia areata as well. Orally can give them prednisone, as well as hydroxychloroquine and other disease-modifying anti-rheumatic drugs for DLE. So how I just had to mention the slap around the world, because as much as alopecia areata is just considered just hair loss, it has a lot of negative connotation, especially for their patients, because they're actually quite stressed out. And when they come, they're stressing over that they have this condition, actually worsens the condition, and they almost would do anything to get back their hair. Thankfully, we're getting better with respect to treating it, and hopefully won't have any more drama regarding this in the future with Jada Pinkett Smith and et al. Just a brief thing, briefly going through tinea capitis with you all. We know that it's exceptionally common in our population, and possibly due to a decrease in the sebaceous, or a shift in the sebaceous or the sebum in her scalp that is causing it more likely to have development of the tinea capitis in our population. And you have various presentations such as the black dot alopecia. Most persons will see the scaling, well circumscribed, scaly erythematous patches, some of along with the associated alopecia. This here is a patient here with a carry-on, and this is one of my patients with diffuse scaling, especially seen in females who do not necessarily patch out like the boys do. Treatment include your Briseofulvin, which is 20 to 25 milligrams per kilogram divided into 2 doses. For 6 weeks, terbinafine, and it is weight-based. Also given for 6 weeks, 4 to 6 weeks, itraconazole for 3 to 5 milligram per kilogram per day for 2 to 6 weeks, fluconazole 3 to 6 milligram per kilogram per day for 6 weeks, or you can give a pulse therapy with 8 milligram per kilogram weekly for 8 to 12 weeks. Of course, you have to monitor liver function, especially if they've had to, if they have to continue for a longer period of time. Topically, they will use the ketoconazole or cycloperox containing shampoo. If the hair is short, they can use it 2 to 3 times a week. Longer hair, once a week is okay. Make sure they leave it on for 15 minutes at least, and then they must use the topical antifungal such as the ketoconazole, cycloperox, clotrimazole, terbinafine twice daily. And they must wash their hair accessories on a weekly basis and not share any products or not share anything while they're being treated. Case number 3, which this is a 77-year-old male with a history of this foot sore for more than 25 years. It hasn't really increased in size, it's just there. Getting lovingly dressed very often with all sorts of things, being given the whole gamut or range of products, including the Curiosine, the Muperosine, Sufrexal, etc., and it's not getting better. And as you can see, it's about a 2 by 2 centimeter ulcerated mass on the foot. This actually, when we biopsied it, it showed an intraepithelial neoplasm, and the differentials included squamous cell carcinoma and choroid neoplasm. So the social implications for this patient, who wants a sore foot man? So imagine he has this thing for 25 years. If it were actually somebody who had a chronic leg ulcer, lots of our chronic leg ulcer patients report having stepping back from having a relationship with anybody because of the chronic leg ulcer. They're embarrassed about it, especially our younger patients, some of our sickle cell patients, and other rare disorders like pyoderma gangrenosum. They step back or weren't really willing to go into a relationship because they have their sore foot. Imagine for this gentleman now that he's going to clinic 3 times a week for how many years? Sometimes he would skip for months, or as you would imagine, for more than 20 years, taking taxi to the clinic, taking taxi back from clinic, sitting down waiting to wait his turn, just all of that. And think about the economic burden on this person for something that essentially, if he was referred, it would have been removed quickly and sorted out many, many moons ago. The medical implications, if it were squamous cell carcinoma, and it's not the most aggressive, it's not as aggressive as melanoma, but it does spread. It could have spread locally, it could have spread into the lymphatics or to other organs, and it would have been very hard pressed for him and his family to accept that he's been seeing somebody in the medical capacity, and nobody realized that this was a type of cancer, and he could have been treated long ago. And as you know, Jamaicans are becoming more and more litigious and we have to bear in mind all of these things when we're managing our patients. This patient was sent to us actually because of a training exercise that we're doing with the Western region on chronic leg ulcer management and training the doctors, nurses, and community health aides. And through that, lots of patients have been coming in. And some of these patients include this patient who is no longer with us. And that patient on the left, as you can see, is an irregular hyperpigmented patch on the leg that was being dressed for at least 10 years. Unfortunately, that patient had malignant melanoma and demised. This patient in the middle had this mass on the foot, also being dressed for at least 10 years. And this patient actually has squamous cell carcinoma. Luckily, it also did not spread. And the patient on the right over here was being dressed initially, but when we did the biopsy, we found that she had mycetoma, and so which is a deep fungal, mycetoma is either a deep fungal or a deep bacterial infection. In her case, no organism was found, but she was actually responding to supersaturated potassium iodide, which we have her on at the moment, and improving with time. Sorry. Something that I want to mention here again with all of these patients and all of these cases that I wanted to highlight to everyone is that a lot of the medication that we have for dermatology is not covered by the NHF, and a lot of them are quite expensive and priced at premium because the manufacturers are aware of, well, especially those with respect to acne. Acne treatments are quite expensive because they're relying on the patient's self-perception and vanity, and they are aware that the patient will pay any amount of money to get their skin looking good. Just want to briefly mention here social media and self-perception. As said by, reiterated by Dr. Bailey earlier, there is increased body dysmorphia, and that is resulting from both the social media as well as reality TV, as he said. And believe it or not, introduction of Zoom meetings like one we're having here during COVID resulted in an increase in cosmetic aesthetic procedures including neurotoxins such as Botox and Xeomin, fillers, and plastic surgery, such as rhinoplasty, etc. And this was because persons, having their Zoom meetings would have on the videos, and they will be looking at themselves in the video, not necessarily looking at anybody else, but looking at themselves in the video and realizing, oh, I need to do this and I need to do that with myself. I don't like this. And then persons staying home during COVID were sitting in their thoughts, thinking about, all sorts of things, all the things that went wrong in their life and all the things that they could improve on themselves. And this is why started seeing a significant rise in or exponential rise in these procedures since COVID. Dr. Bailey also mentioned that younger persons are becoming even more obsessed with improving themselves, and this has to do with social media. Currently, we have the technologies so that you have filters and live filters, so you can have a video where the person can actually modify themselves in the video, and the patient and our children are seeing these videos and thinking that these persons are perfect, not realizing that they are heavily modified, and so they're feeling inadequate within themselves and are actually looking out for things to improve themselves at such young ages. And exposure to pardon me, sorry. Exposure to all of these ads, etc., on social media have seen a rise in what they call Sephora kids. And these are children who are elementary school age children who have been going into Sephora, Ulta, pardon me,
Dr. Lorena Mura Green, thank you so much. I know you've reached social media and self-perception, and you're reaching strategies for physicians. We're just loving it. We're seeing all of these emojis going up. If you're ready, you may continue, please. Would you like me to read? Let me read in the meantime, all
sure,
right?
thank you.
Strategies for physicians. Psychiatry and dermatology go hand in hand. Doctors need to have a lower threshold for screening for depression in patients with chronic skin conditions. Quality of life of dermatology patients far exceeds other chronic conditions such as diabetes, hypertension, and asthma. Household cohabitants are also likely to be affected. They'll have burnout, stress, and loss of sleep, especially when children are involved. There's negative impact at school and also negative impact at work. Frequent attendance to clinics, missed class lessons, poor sleep impacting concentration, and bullying or scornful behavior by others. We need to have in our arsenal tools that we may use to assess patients. Want to bring on the next slide? Thank you. So we see
so this is the Dermatology Life Quality Index. Thank you, Dr. Buckland. Thank you so much. I'll see if I can finish this.
All right.
But this is a Dermatology Life Quality Index, which is questionnaire developed by Cardiff University. And what they look at is to measure how much your skin problem has affected your life over the last week. And it has been validated and translated into about 85 different languages, and has been modified for certain or different diseases such as atopic dermatitis and psoriasis. And how you interpret it is that if you would score up, make the score, the patient will make the score, and if they're between 0 and 1, there's no effect on their life. And if between 21 and 30, there's extremely large effect on the patient's life. And this is a simple tool that you can have in office to assess patients who have chronic skin conditions. And because as we know, chronic skin conditions have a tendency to cause psychiatric disorders. Another tool that you can use, which most of you will be aware of, is the depression questionnaire, as listed here. And and you will check off accordingly if the person is having likely major depression, and you will refer to the psychiatrist if necessary. Other strategies that we need to employ include arriving at the correct diagnosis earlier. With this will reduce unnecessary stress and economic burden on the patient, because again, like I said, most drugs are not covered by NHF, and the drugs marketed for dermatology tend to be priced at premium. I'm sure some of you know some of the prices for some of these drugs. If after 3 visits with various treatments and there is no improvement, please don't hesitate to refer or consult one of your dermatology friends. And there are over 3,000 diseases that dermatologists have that we need to know of. All right, so it's a vast world in dermatology. Some of the conditions that we need to know are so rare, and most of you would not ever have been exposed to them. And with just referring to the right person or to a dermatologist who would know, okay, no, this is a condition, there's no treatment for it. You can go, that person will now know that, oh, I was born with this condition, it is not contagious, etc., etc. And they will be able to be at rest or at peace to know that that the condition that they have is not a problematic condition. Again, have a low threshold for screening for depression and impact on quality of life. And maybe we might have to consider the creation of a psychodermatology unit. And these are my references. And thank you for listening to all of my coughing, etc.
You're a real trooper. Even though you have your own stress, you still loved us enough to come forward and present on this very important topic, the psychological impact of dermatologic conditions, strategies for improving patient self-esteem and mental health. I remember you had a slide that showed that the skin and the nervous system came from the same place. And as you said it, I said, oh, because there is a technique called the havening technique. They have self-havening, where actually just gently stroke, just like this. And if first of all, you can think to yourself, how bad is my distress? Some people may say, oh, go from a scale of 0 to 10, where 10 is worse and 0 is, or 1 is a little bit. Sometimes the patients cannot think in numbers. So I just say, tell me, show me with your hand, So this is very big and this is very little. And then once you do that, I say, okay, just do this. Think about it and just continue doing this. And because skin and nervous system are connected, the stimulation of the skin goes through connected pathways to the brain where we have the stress, the amygdala, and it depotentiates the AMPA receptors in the amygdala, where emotion, horrid emotion, is stored in a memory. But because the delta waves are now generated, this is what happens. The delta waves, very, very slow waves, now it unglues the issue so that the stress is actually now relieved. So if you have a stressful thing, you just gently just do this, or you can do this. I feel so good. And literally when the person leaves room happier, with more joy. They may have a condition, but when there's more joy in a person's life, then there's joy in the skin too. And I think in the journey, the person will learn to accept, and on the journey, find that the skin also makes a journey. The skin will make a journey. However, we need support. And so we never leave this person alone, just support. Thank you very much. And we can also practice this on ourselves, find that this works. Because in 2-2s, you feel, stress is gone. You feel like you can go on to the next moment. All right, so we want our patients to also go on to the next moment. Refer to the dermatologist early, especially if there's a problem. You know, the other day I referred a person had vesicular eruptions on the foot and did cultures, all kind of bacterial infections were there. But each time it was a new one. And I said, this is so strange. But it was still there. So I sent her to a surgeon to just assist. And you know what he thought it was? So spot on. It was actually herpes manifesting on the foot. And when he put her on acyclovir tablets and acyclovir cream, and then she came back, I said, whoa, he actually hit bullseye. So we must also think of other things. We could actually have a virus on the foot, you know, doesn't have to be bacteria or fungus, you know, so sometimes we may need to have other colleagues refer to our colleagues, because at the center of all this is the patient. It is a patient. And who is to get better? The patient. And then we are on that journey with the person, so the person feels, oh, you know, doc, thank you so much. And then you also help the person to embrace other team members to get better. So thank you so much, because these are strategies for improving patient self-esteem and mental health. And remember the evening. Thank you so much. Let me see question and answer questions in the area here. Is there any connection with warts and psychotic medications?
What type of warts are you talking about? The genital warts or?
Anyway, they want to know if there's any connection.
Not that I can think of, no.
All right, fine. Let's go to the next one. Skin manifestations of internal malignancy in psychiatry. That's a big one.
Okay, so that, no. We've had patients who, with cutaneous lymphoma, or HTLV as T-cell lymphoma, have depression and anxiety regarding their condition, and they are more likely to, because as HTLV is not, especially with HTLV, it's not just a lot. We were taught initially that it's you only can get one type of manifestation. If you actually are going to manifest anything, you can actually have several different types of or conditions all appearing at several over the years. So I've had one particular patient of mine that comes to mind is one who has she had TSP-HAM, and she was now presented with HTLV associated arthritis and HTLV associated Zika syndrome, and she was quite distraught about all of this because in her mind, a long time ago, she was told that the only thing that she's going to manifest or have is just a TSP, ham, and nothing else. And so to see that all the things were now manifesting was actually quite distressing for her.
Mhm. How long can one use terbinafine cream and ketoconazole shampoo for? That's one question. And is it safe being used for years due to fungus in the head that will not go away?
Okay, so for seborrheic dermatitis, which is what the most of our patients would be using, the antifungal shampoos, you can use it for life. It's quite safe. It's actually ketoconazole has been shown to be both antifungal as well as has some amount of hormonal effect in the sense that it's useful for pattern hair loss or androgenetic alopecia. And they know where they don't actually have it as an actual listing in the marketing for ketoconazole, but it is known to be useful for that. And so patients can use it for a very long time. Similarly with the for seborrheic dermatitis, you can use the topical antifungals as well, or the topical steroid creams to help to keep or suppress the seborrheic dermatitis. No real issues long term.
Thank you so much. Well, you're a real soldier. You're a real soldier. Thank you so much. You have really brought on a lot of information and guided our thoughts on strategies for improving patient self-esteem and mental health, and shown us the various conditions to help us to recognize and also to be aware that we are to think of ourselves as working in a team. Very important.
Thank you.
Yeah. I'll ask Miss Tanjani Turner, medical representative for Medimpex, to move the vote of thanks.
Okay, no problem. Can you hear me?
Yes.
Okay, great. Good night, everyone. I am deeply honored and I am deeply honored to extend my heartfelt gratitude to everyone for participating in our annual ethics webinar. Today's discussions were essentially to the field of cosmetic dermatology, and your presence and engagement made it all more impactful. Firstly, I'd like to thank Dr. Bailey for his insightful presentation on the ethical dilemmas of cosmetic dermatology. Balancing patient autonomy, safety, and societal impact is indeed a complex task. Your discussions on the physiological benefits of cosmetic surgery, the significant influence of reality TV on societal perceptions, and issues like body dysmorphia disorder were particularly enlightening. Your conversation on the role of social media in shaping young professional views on beauty and self-worth underscores the need for responsible communication and realistic portrayals. A special thank you to Dr. Muir Green for pushing through your presentation on the psychological impacts of dermatological condition strategies for improving a patient's self-esteem and mental health, highlighting skin diseases and their profound effects on mental health opened our eyes to the crucial strategies needed to support our patients. Your discussion on how mental health issues such as delusional disorders, depression, OCD, and eating disorders can manifest a dermatological issue highlighted the critical intersection between mental health and dermatology that we must understand and address in our practice. So I just want to extend a special thank you for that good presentation. Very nice. I also would like to acknowledge the contribution of our organizing committee for their hard work in making this event possible. Their dedication ensures that we continue to foster a community that values ethical practice and patient well-being. And lastly, I want to thank you all, our attendees, for your active participation, engagement. Your commitment helps us all to provide better care and positively impact our patients' lives. Thank you once again, and I look forward to seeing you all at our next event.
Thank you.
Thank you very much, Ms. Turner. And so I'm Dr. Alith Buckland. I was your moderator for this evening. I wish you all a good night and happy sleeping. Good night, all.